hopefully, yes, hopefully this will be educational for you. So I'm going to talk a bit about what we currently know about the neurobiology of anxiety disorders, and then talk a bit about some future directions that we're exploring in Southampton. And this will include some of what was mentioned in the introduction about experimental medicine and neuroimaging. So first off, just to say, this work was funded through a training fellowship with the Medical Research Council, and I'm currently funded by the National Institute for Health Research in the UK, neither of which had any input into this presentation, and I don't have any other conflicts of relevance. So I want to start at quite a high level, thinking about anxiety and fear. And I think this kind of summarizes quite nicely what anxiety and fear are. And you can kind of think of them in relation to how far away a threat is. So if you imagine you're in an environment where there may be a threat, you're in a kind of pre-encounter state, this is fairly equivalent to what we would consider anxiety. There's kind of hypervigilance, non-specific threat that's out there. And you then move along this kind of gradient to where a threat has been detected. So you're selectively attending to that, thinking about how you might respond. If you were an animal, you might notice motor freezing in the animal while they're kind of trying to keep still and not attract attention to themselves. And then when the threat is imminent, you're in a kind of circa strike defense mode. So this is when you're in your full fight or flight response, your panic response, or your freeze response. And as an aside, there's a school of thought that possibly catatonia is our human equivalent of this tonic immobility. So when you're at this end, you're very much into the realm of fear. And I think this is relevant because it maps very much to the kind of neurobiology and neurocircuitry of what's going on. Anxiety disorders, probably unlike other disorders to a point, and we can talk about that in the Q&A if you like, but they definitely are more dimensional. Anxiety is a normal response. You know, you do need it to survive, but there are people who are higher risk of developing dysfunctional anxiety, people with kind of personality risk factors. So this anxious personality here that comprises kind of a mixture of neurotic traits, perfectionism, maybe shyness in terms of social interactions. But when that gets out of hand and dysfunctional, you can end up with an anxiety disorder. And people are probably somewhere along that line. And we know that there is a genetic basis to some of these risks. If you're interested, there's a very good review by Dan Stein and colleagues that was recently published in 2023, looking at these kind of genetic risks for kind of anxious personality features and anxiety disorders. I'm not a geneticist, so I'm not going to go into too much detail about that because I don't really understand what all the genes do. But if you're interested, you can look at that. So when I'm talking about anxiety disorders, what am I talking about? And there's a few that are listed in the ICD-11. There's 7 actually. I've only listed 6 here. And that's because the 7th, selective mutism, I would consider is a kind of a subtype of social anxiety disorder. I think I might give up on the pointer. Oh, unless this one. This is much better. I'll use this one. So There are these 6 disorders defined in the ICD-11 under the chapter of anxiety and fear-related disorders, which I think comes from the research kind of showing there's these 2 things, there's anxiety and fear. And probably the prototypical anxiety disorder, generalized anxiety disorder, this kind of prolonged excessive worrying that's not restricted to any kind of specific circumstance, so-called free-floating anxiety. And then you kind of go down and get more specific. So separation anxiety disorder, this is a fear of separation from loved ones, or a fear that some harm might come to them when they're separated. Social anxiety disorder, so specific fears around being appraised negatively by others in social situations. Agoraphobia, fear and avoidance of situations where you can't escape, or you might struggle to get help. Simple phobia is a specific fear of a specific object, animal, or people. And then panic disorder, these unexpected surges of severe anxiety, peaking within about 10 minutes, lasting about half an hour or so. And patients often believe they're in imminent danger of fear or imminent danger of death or fear of going mad. And you can actually map these roughly to kind of the most anxiety-related and the most fear-related, which may be relevant for their neurobiology. So I'm going to talk a bit about what we know about the functional neuroanatomy of anxiety disorders. And there's a very nice review by Pennings and colleagues where this first diagram comes from. And this is from a chapter in the Cambridge textbook of neuroscience for psychiatrists that I wrote looking at this. And generally, the way the neurocircuitry works is that you get inputs into the thalamus. The thalamus sends inputs to the lateral amygdala. And if there is threatening information, that will get appraised by kind of frontal centers. The main ones being kind of medial prefrontal cortex, anterior cingulate cortex. If you need to have a quick fight or flight panic response, the central amygdala sends outputs to the periaqueductal gray, locus ceruleus. That sends information down to your kind of autonomic nervous system. And your somatic features like increased heart rate, increased blood pressure are mediated in that way. And I keep going back to this, but you can actually map where anxiety and where fear happen in this system. And this has been done through quite a lot of translational work, really, but I'm just going to summarize a bit of it for you. So Dean Mobbs and colleagues had some really clever fMRI designs looking at this to try and understand which bits of the brain do which part of the anxiety response. So they set up this task where there was a predator, in a sense. And in one condition, you'd get shown a predator, and there would be no threat at all from the predator. And the aim would be to escape the predator. So the predator starts moving around, and then after a while, the participant is allowed to move their little piece, which is the triangle, around the board, and your aim is to try and escape. On some of those conditions, there was a threat. So they might have had a threat of a single shock or a threat of 3 shocks. And again, they would be cued to that. The predator would start moving around the board, and at different time points, the participant would then be allowed to move and try and escape. So what they're trying to set up here is this idea of this kind of generic threatening environment, which is cued by one of these 3 things. That's your kind of anxiety phase. And then you've got this kind of post-encounter phase, and then you've got circa strike. So they've tried to very nicely map out the three bits of the kind of anxiety continuum there, and look at which bits of the brain are active in each of those. And to summarize, there's been lots of studies that have replicated this since, and this is from a review looking at all of those. And to summarize, when When you're in the anxiety phase, it's very much these prefrontal cortex regions and lateral amygdala that are active. So it's all that information at the frontal parts of the brain that are important. As the threat gets more proximal, as you're getting towards your circa strike, your panic area, the frontal parts of the brain shut off. And you have your central amygdala and your periaqueductal grey talking to each other to activate your fight or flight. What's the advantage of shutting off the frontal lobes in that situation? Save time. Your thoughts don't get in the way. You will just act. That's important, I think, for thinking about our patients. They don't think in these situations, and you see it a lot, not just in anxiety disorders, but in other kind of emotional dysregulation type pictures. People just act, fight or flight. They're not thinking. In fact, the brain is actively working against you thinking, because that might get you killed back in the day. Hopefully not these days. I think it's worth thinking about, though, what the frontal areas are doing, because they're not just kind of appraising the anxious stimuli. This was a really nice study by Bishop and colleagues that was published in Nature Neuroscience in 2004, where healthy volunteers were asked to do a very simple task, really. They were shown pictures of houses, and they were asked to say whether the houses were the same or different. And they were also shown these distractors. So there were faces where there were different emotions, so they might have been fearful faces or neutral faces, designed to distract the participant. And the aim, therefore, was to do the task without getting distracted. And of course, it's more easy to get distracted when there are fearful faces. Interestingly, when they were looking at the difference between the kind of fearful trials and the neutral trials, they found this region was associated with the participants' anxiety, and in fact, lower activity in this region, which they called rostral anterior cingulate cortex. I think I would say it's more ventromedial prefrontal cortex, but that's getting into a debate, really. The point is, it's around the middle prefrontal cortex. And lower activity there led to higher anxiety, which suggests that that region is activating some kind of control, some kind of brake on the panic response. So if you imagine the two parts of the brain are almost in competition with each other all the time, either trying to regulate and stop that panic response, or the panic response is trying to regulate and stop you thinking. And depending on the demands at the time, that depends on which areas of the brain are active. You can, in fact, alter this as well with different kind of regulation strategies. So this is from a meta-analysis. No, sorry, this is not from a meta-analysis. From an experimental study in healthy volunteers, where they were shown emotional pictures and given different strategies to try and manage their emotions. So they were either asked to distract themselves from the image, or they were asked to cognitively reappraise the content in the image. What do they mean by that? So they mean taking the content of the image and thinking about it in a different way to make it less emotional. So, for example, if there was a picture with a person with a knife, maybe you would say, oh, well, the knife is a toy knife. It can't really hurt anybody. And that can help reduce the emotional response. And what you can see is that cognitive reappraisal strategy really robustly activates very frontal areas. More so than distract. When you're getting distract, you're moving kind of more medial. And then both of these, over just looking at the images, involve kind of frontal centers. So you can actually see when people are actively trying to control their anxiety response, you're activating those frontal regions. This is a meta-analysis where those kind of reappraisal studies were carried out with patients and with healthy volunteers, and they meta-analysed across these to see which areas of the brain healthy volunteers use more and which ones patients use more. And you can see healthy volunteers reliably activate these frontal areas a lot more than patients do. Patients activate other kind of regions. There's temporal lobe here, maybe because they're talking to themselves in the scanner, who knows, but you're not really seeing these frontal regions. So it suggests patients with anxiety disorders, their kind of threat detection is shifted, and they're using their kind of panic systems a lot more than their anxiety regulatory systems, their frontal regions. The good news is you can train it back, so you can correct this to some degree. This was from a really nice study where patients were given different strategies for managing anxiety. They were either randomized to a mindfulness-based stress reduction program, so trained in mindfulness techniques, whereby you become better at noticing your emotions, noticing the environment, and using that information to kind of manage your anxiety. Or they were given a generic kind of education about stress management. And what you can see is that before that intervention, areas like here, the anterior cingulate cortex, were underactive in these patients. After the intervention, it's much more active, significantly more than the patients who didn't get that intervention. So you can train a lot of these systems back, and that improvement is associated with improvements in anxiety. So these mechanisms actually seem quite key to people's experience of their anxiety. Moving on to neurotransmitters, and there's two that I'm going to mainly talk about to begin with. So one of which is GABA. We know that GABA is very key in anxiety disorders for two reasons, really. One is that if you give GABA agonists, such as benzodiazepines, you improve anxiety. The other is if you give GABA antagonists, you worsen anxiety. So if you give people flumazenil, for example, they will feel more anxious. And you can see that benzodiazepines bind to a different binding site from GABA itself, but both result in conformational changes of this channel, which potentiate the action of GABA itself. The really important thing, I think, that's likely to come about in the future is that we're starting to understand that these different subunits have different functions, and it seems that particularly this alpha-2 subunit might be the anxiolytic part of the channel. And I think there is work to develop agents that specifically target that subunit as opposed to other ones, which may be involved with adverse effects. So that may be coming in the future. Probably the other neurotransmitter most associated with anxiety disorders is serotonin. And the role that serotonin plays is very complex and not fully understood. This is from a review looking at animal models of anxiety disorders, and specifically looking at where animals have had knock-in and knockout of different receptors, serotonin receptors, and looking at the kind of antidepressant and anxiolytic-like effects of serotonin at each of those receptors. And what you can see is that the picture is very mixed. So, for example, at some receptors, you see that blockade of serotonin, like 5-HT3, is anxiolytic, or at 5-HT2C, blockade seems to be anxiolytic, but also Serotonin seems to be anxiolytic, which is a bit confusing. Same with 5-HT1A. Blockade is anxiolytic, but also serotonin is anxiolytic. Autoreceptors is more specific by the looks of things. You can see it's a real mixed bag, and trying to disentangle what's going on here might be key for the future. But there are a couple of important things about serotonin that are worth knowing, and I think are worth knowing for clinical practice. So I mentioned that kind of the 5-HT1A autoreceptors have quite a clear link with serotonin, and you can see that here in the brainstem. Serotonin seems to directly act there and inhibit panic responses, and do that quite quickly. So when you're giving your SSRI, you're likely to dampen down these kind of features of anxiety pretty rapidly. But slightly annoyingly for clinical practice is that serotonin upregulates anxiety in these frontal regions. Why might it do that? Any thoughts?
Could you repeat the question?
Why would serotonin activate these regions and increase anxiety?
Yeah. Probably due to the distribution of receptor areas, I think.
There's a good behavioral reason. So like I said, like we talked about before, these frontal regions help you think. If you've got a threat that's quite distal, and you're using these frontal centers to decide how to respond, to regulate your attention, those sorts of things, you don't want to accidentally have a panic response too early, right? If you dumped all your resources, all your sugar, all your adrenaline and everything before you're in the circus strike phase, before you're in the phase where the threat is very proximal, that could get you killed. You need to be able to stop that response before you need it. So serotonin, by inhibiting here, must be activating here to kind of act on that brake. And particularly, it seems that 5-HT2C receptors in the amygdala are involved in that. So over time, if you flood that with serotonin, you downregulate the activity of those receptors. So that's probably why SSRIs are helpful. They reduce these somatic features quite quickly. They increase anxiety at first, but over time, probably about 2 weeks or so, you see that response. So I always warn patients that they're likely to feel more anxious when I first start them on SSRIs. And that's true with depression as well, that they're likely to notice some kind of jitteriness, some kind of hypervigilance, but after a couple of weeks, that should settle down. So I think that's worth knowing and understanding. Right, so I'm going to talk a bit about future research directions now, things we're doing in Southampton, looking at possible targets for anxiety disorders, which are orexin and endogenous opioids. And I'm going to have a bit of a break from the science for a minute to show you some pictures. So I don't know if you've had speakers from Southampton before, or not for a while anyway. So just to introduce, this is where Southampton is in the UK. It is near the sea, or on the sea. Well, it's in a river that goes to the sea, but it's a port, really. So this is to show you, we get big kind of ocean liners and cruise liners coming in and out of Southampton. Southampton is famous for where the launch of the Titanic was, sadly never to return, but that is still famous now for doing lots of cruises and things. The water is not water you'd want to swim in, really. It's polluted. It's a harbour rather than a beach. But we are near some very nice beaches. This is Durdle Door, which is in Dorset, just down the road, and quite a sight. We do get people jumping off of Durdle Door, which the water isn't that deep there, so they regularly injure themselves. And you'd think after one person had done it, others would know not to, and yet they keep doing it. So, but it's a very nice beach, and this is part of what's called the Jurassic Coast. There's a lot of fossils from the Jurassic era in the beach that you can find. We're also very near the New Forest. This is a picture of the New Forest. Lovely countryside around Southampton, which, you know, if you came to visit, you might want to see. This is where I work. So this is College Keep, which is our university clinic, which is in town, and actually just over from the first picture where you could see that ocean liner, it was just round the corner from there. And this is what the university campus looks like, which is slightly further away from the sea. And you'll notice all the trees. They call it, the county that Southampton's in is called Hampshire. And we call it leafy Hampshire because it's all full of trees and leaves. And at this time of year particularly, a lot of blossoms, which are very nice to look at. Okay, so that's kind of setting the scene of where we are in Southampton. And we do research really looking at kind of treatment discovery in anxiety disorders through trying to understand the mechanisms of anxiety disorders. And I want to teach you about, or talk to you about something that we've been interested in recently, which is the endogenous opioid system. This is from a meta-analysis of PET studies looking at carfentanil binding in healthy volunteers. Carfentanil is a radio tracer that you can use to look for opioid receptors. And this is where the highest distribution, the highest amount of receptors are in the brain. You can see the amygdalas are really lighting up on both sides there, striatum as well, but also areas that I've told you about are really important in regulating anxiety, right? So medial prefrontal cortex here, extending into rostral anterior cingulate cortex, full of opioid receptors. Orbitofrontal cortex as well, full of opioid receptors. And it got me thinking, if these regions that we know are key in regulating anxiety are full of these receptors, then maybe this chemical, these endogenous opioids, are doing something to manage anxiety. And it may be that that's the case. So the endogenous opioid system is made up of a number of different chemicals. You might have heard of some of them. So there's beta endorphins, metenkephalin, leuenkephalin, proteins like that. And they bind to 3 different types of receptors. So there's mu opioid receptors, delta opioid receptors, and kappa opioid receptors. They're thought to have slightly different functions, but I'm mainly going to be focusing on mu opioid receptors and the mu opioid system, which are inhibitory receptors. And there's some evidence that they might be involved in regulating anxiety. This was probably the first study to look at this, and they utilized naloxone, which is a mu opioid receptor antagonist. And quite small numbers. They recruited 22 patients who were about to have some orthopedic surgery, which, there will be some anxiety, some trepidation about that surgery. And they randomized them to receive either IV naloxone or placebo 30 minutes after a dose of IV diazepam. So it seems, I don't know what happens in Turkey. I don't think this would happen in the UK now, but back in the 80s, it looks like you would give people IV diazepam before a surgery just to kind of calm things down. Would that happen here now?
Generally, we give lorazepam mostly.
We use
lorazepam mostly.
Lorazepam,
yeah.
okay, yeah. Would it be IV?
No, we don't have IV
No,
option.
yeah. I'd be surprised, but this is what they did then, and what they found was that the diazepam really nicely reduced people's anxiety, but when they then gave the naloxone, their anxiety increased again. So the effect of the diazepam wasn't fully attenuated, but it was partially attenuated by the naloxone, which, given that it's only a mu opioid receptor antagonist, it's not known to have effects anywhere else of relevance, suggests that at least partially the actions of diazepam seem to be mediated by endogenous opioids, which is interesting. Subsequently, there was this study published by Libizan and colleagues in 2002, looking at what happens when healthy volunteers look at pictures, aversive pictures. And what they found here, this is a map of carfentanil binding, of regional cerebral blood flow and fMRI responses to these pictures. And what they found was that particularly there was increased kind of responses in the amygdala and in the inferior temporal cortex there. And that mapped onto where the mu opioid receptors were found on PET imaging. There was a big relationship. So it suggested that patients who, and this is that here, so patients who had higher ability to bind mu opioids as a result of looking at aversive images also had the highest regional cerebral blood flow in those regions. So suggesting that something about looking at aversive emotional stimuli activates the kind of endogenous opioid system. More recently, this was in 2016, a study by Harker and colleagues looking at social threat learning in humans. And this was the paradigm they had. So healthy volunteers watched a video where someone was shown different colored squares. Some of them were associated with an electric shock, so the blue ones here, and the yellow ones were a threat-free, threat-neutral condition. And they were randomized to receive either naltrexone, which is an oral mu opioid receptor antagonist, or placebo, before the observational learning session, and then they were tested with an immediate expression test and a long-term expression test. So they were shown these stimuli and asked to rate their anxiety. So they looked at both their anxiety and also physiological markers, so skin conductance markers, and you can see when given the naltrexone, the responses to the threatening stimuli were increased compared with placebo. Likewise, when they were tested with fMRI, patients who'd been, or healthy volunteers who'd been given the naltrexone showed increased amygdala activity when shown the threatening pictures, and that correlated with increased skin conductance response. So it looks like that when you inhibit the endogenous opioid system, you're getting larger effects of social threat learning, larger effects of anxiety. So I was interested in trying to understand how might inhibiting this system lead to increased anxiety. What exactly is going on? And so we did a study with collaboration with Henk van Sternbergen, who is based in Leiden, and Nick van der Wey as well, who's based in Leiden. And Harry and Laura, who was a visiting psychiatrist from Milan, helped us with data collection. And I was supervised by David Baldwin and Matt Garner, who are based in Southampton. We were interested in measuring both explicit and implicit anxiety processing in the scanner, looking at the effects of the endogenous opioid system. So we recruited 40 healthy volunteers, and we did one scanning session with them randomized to receive either naltrexone, 50 milligrams, to inhibit the endogenous opioid system, or placebo. And they then crossed over and received the other condition a week later, at least a week later, and had a second scan. And we asked them to do a couple of tasks in the scanner to try and understand what role the endogenous opioid system might have in regulating anxiety. These were the two tasks. So the first task was an emotional reappraisal task. So like I explained before, in this task, people were shown various images, some of them quite aversive in nature, like this car crash here, some of them much nicer in nature. I don't think we've got a nice one on that example. That's bad luck. But some of them nicer in nature, more neutral. And we asked them to regulate the emotional content of that image by reappraising it. So by, as before, thinking differently about the content. So maybe, these were toy cars, or it was part of filming for a film, or something like that, to kind of reduce the emotional content. And we then asked them to rate how they felt from, very distressed to very relaxed. And we also asked them to do a FACES task to try and get at implicit emotional regulation. So in this task, participants were shown in blocks, either fearful faces, neutral faces, or happy faces. And what we asked them to do was identify the sex of the face. So we didn't tell them we were interested in their response to the emotion, although we were. But so they hopefully weren't aware of that, but that they were at least looking at the faces and processing them, and then telling us what the sex was. So we looked at these two tasks, and here's what we found. So with the emotional reappraisal task, first we looked at the behavior. So did reappraisal success differ between placebo and naltrexone? And there was no difference whatsoever. So this was when looking at negative images, looking at the kind of contrast of reappraise to just looking at them, and how much did their distress reduce. And you can see that the distribution of those for both placebo and naltrexone are very similar, and there was no significant difference. And perhaps, given that there were no differences behaviorally, there was no significant difference on the fMRI either. So the top here is naltrexone, the bottom is placebo. You can see very broadly the same regions are involved, and they're the regions you'd expect. So based on the previous studies I showed you, we found lateral prefrontal cortex, particularly orbitofrontal cortex, involved in that kind of emotional reappraisal strategy. But when it came to the FACES task, we found something quite interesting. So this was looking at placebo compared with naltrexone when healthy volunteers were looking at fearful compared with happy faces. And you can see that when they were on placebo, there was increased activity here in this kind of medial prefrontal cortex, anterior cingulate cortex region. And that was not present in the naltrexone condition, which I think is interesting. So I think it's quite a similar region to this one, the one that I showed you before from Bishop and colleagues. And that maybe, the patient's attentional control systems are being activated. And when we give naltrexone, we're inhibiting that. So we've inhibited that control a little bit. So possibly their anxiety responses, at least to implicit information, when they're trying to control and do a different task, maybe they're finding that more difficult. But we didn't actually have a measure of anxiety in that task because it was implicit. So we don't know that for sure. But that might have been what was going on there. So maybe in future we need to understand a bit more about what the endogenous opioid system is doing, but it might be a treatment target in future. And I'm thinking about possibly doing something looking at buprenorphine, which might be interesting to do. So changing tack slightly now. So we've also become quite interested in the orexin system recently. And this is research that's really being led by Harry Fagan here, who is an academic clinical fellow in Southampton. And recently, together with Professor Katarina Domschke in Freiburg, we published a review looking at the orexin system in anxiety disorders and whether potentially it might be involved in the neurobiology and whether it might be a potential treatment target. You can see here on the bottom the projections of orexinergic neurons. You can see the amygdala is involved as well as the bed nucleus of the stria terminalis, which I haven't really talked about thus far, but does seem to be key in anxiety processing. And there is some evidence in the literature that orexin might be involved in anxiety disorders. So mostly orexin is known for narcolepsy. Narcolepsy is a condition where people will, in response to kind of intense emotional situations or other triggers, have sudden attacks of sleep. So they will suddenly fall asleep, and that is known to be related to the destruction of orexinergic neurons. And orexin receptor antagonists, therefore, have been developed for insomnia, the thinking being, well, if you destroy orexinergic neurons and people have attacks of sleep, then maybe if we block that system, we can help people sleep, which makes sense. So does that suggest then that orexin is important in arousal? Arousal being quite a key part of anxiety and threat processing. And therefore, if orexin is important in arousal, could then orexin receptor antagonists not only help with sleep, but also be anxiolytic? Possibly. There is some data out there to suggest that orexin might be involved in arousal. So this was a study where I'm not sure they were particularly looking at arousal, but it is quite interesting. So 53 patients presenting to emergency departments with suicidal behavior. And they were classified into kind of patients who have a history of panic or MDD, or no panic or MDD. And they looked at, in the CSF, what the orexin levels in cerebrospinal fluid, what the orexin levels might be in those different groups. And what was quite interesting was in the panic patients, there was significantly higher levels of orexin in their cerebrospinal fluids. So this was the panic without depressive features group of patients. So it's a signal that maybe, orexin heightens arousal. It kind of heightens the potential to trigger panic attacks. Likewise, another study by Acker and colleagues, published in 2020, looked at orexin levels in the plasma as well as cortisol levels. And they collected a mixed bag, really, of anxiety disorders in adolescents. So there was a lot of social anxiety, a lot of generalized anxiety, some panic, a lot of smaller number, and some separation anxiety disorder. They compared the plasma samples with 32 adolescents who did not have anxiety disorders. And what they found was that lumping all those together, the anxiety disorder group had a significantly higher level of plasma orexin A than the control group. So again, there's a signal that perhaps this system is involved in kind of arousal and increased anxiety. Interestingly, if you This was published by Gorka and colleagues in 2022. If you give suvorexant, which is a orexin receptor antagonist, in healthy volunteers in an unpredictable threat paradigm, you see a reduced response to that threat. So in the NPU paradigm, you have three different conditions. You have a no-threat condition. You have a condition where there will be a predictable threat, so usually it's an electric shock. That shock will happen at specific time points so that it's predictable. And then you have an unpredictable threat, so like you will be shocked at some point, but you don't know when. And it's thought that the unpredictable threat is the most like anxiety disorders, if you're trying to model that in healthy volunteers. And what you see is with the suvorexant, you have a much lower startle magnitude, significantly lower startle magnitude than placebo in that condition. So again, suggesting maybe it has anxiolytic properties. In Southampton, we use a different model of anxiety. So we use the 7.5% carbon dioxide inhalation model of anxiety. And in this model, we ask healthy volunteers to inhale air that's been enriched with extra carbon dioxide, so 7.5%, but the same amount of oxygen. So they don't suffocate, they don't get hypoxic, but they do get an anxiety response. And we know that this can model quite nicely the features of generalized anxiety. So this is from Bailey and colleagues in 2005. You can see subjective anxiety is significantly increased with carbon dioxide compared with air, and also autonomic features of anxiety as well. So systolic blood pressure and heart rate are significantly increased. And depending on the concentration of that gas, you can get different responses. So we try and induce a generalized anxiety response with 7.5%, which is quite a low concentration. If you give 35% as a single inhalation, single total vital capacity inhalation, you can induce panic in patients. And they use that model in the Netherlands to look at panic disorder. And actually, they've tried giving a selective orexin-1 receptor antagonist in that panic model. And you can see they compared it with alprazolam. So this is the agent here, JNJ 6139. I don't know if it's going any further, so it doesn't have a name. But they looked at panic symptoms in this model. You can see at this 90 milligram dose, there was a significant reduction in panic, not as much as alprazolam, but not too bad. However, there was no change in the cardiovascular parameters. So this was just the subjective feeling of panic, which is interesting. And I'm not sure exactly what that means. So whether the subjective feeling was different or whether this represents demand characteristics, it's unclear. But if we go back to this diagram, you can see up here in the top right, a lot of these regions aren't just orexin-1 receptors. These are the red ones here. These purple regions, like the basolateral amygdala, bed nucleus of the stria terminalis, they have both orexin-1 and orexin-2 receptor antagonists. So maybe you'd get a better response if you used a dual orexin receptor antagonist. And this is what we are planning to do and due to start imminently. So we're going to recruit 50 healthy controls and give them a single dose of daridorexant, which is a dual orexin receptor antagonist, and match placebo. They're then going to go through the carbon dioxide challenge, and we're going to measure psychological symptoms of anxiety, but also the autonomic outcomes. And we'll see whether we see any signal for orexin there. And if we do, the plan is to take that further into further clinical trials. We'll see. So, a tour of what we currently know about anxiety disorders and where the future might come. So, we're beginning to understand the neurobiology of anxiety and fear-related disorders, but I think we're really only still just beginning to understand that. We have a better understanding of how it functions in normal life, but in patients, I think that understanding is still coming. Endogenous opioids may have a role in that regulating attentional control when there is kind of threatening stimuli, and that's something that needs to be explored further. And antagonism of the orexin system might emerge as a novel treatment target in future, and maybe I'll come back and let you know the results of that at some point. So I want to thank everybody who's been involved in all of these studies, David, Matt, Nick, everyone at University Hospital Southampton who have helped with the scanning, and our collaborators in Leiden and Freiburg. And I'm happy to take any questions and have a discussion.